Hello everyone. The second patient is a 65-year-old male with polycystic kidney disease. 10 years ago, his sibling brother served as the kidney donor. His current maintenance therapy consists of steroids, tacrolimus and mycophenolate mofetil. And in the past year his serum creatinine had gradually increased and some mild proteinuria was noted. Blood pressure 140/90 and results from renal ultrasound, tests for donor-specific antibodies and check for BK virus in the blood were normal or negative. Tacrolimus levels were in the defined therapeutic range. Maybe here you should take some minutes to formulate your own thoughts for this clinical presentation. You can discuss this online and we will be happy to help where needed. Keep the questions in mind as seen and discussed in the first patient. The questions to answer here are: what is the clinical syndrome? What is the most likely cause for renal dysfunction? What is the underlying pathophysiology? How can you differentiate these causes and what is the best treatment option? Also in this case, a renal biopsy was taken.
The overview of the renal biopsy shows multiple areas in which the tubes are atrophic, characterized by these enlarged, irregular tubular basement membranes and reduction of the tubular diameter. Moreover, there's quite a distance between the tubes, and this area is filled with collagen fibers, best appreciated in this silver staining. Together, we call these changes interstitial fibrosis and tubular atrophy, or in short, IFTA. In almost all instances, IFTA is accompanied by a non-specific lymphocytic infiltrate, like here. It is important to search for areas in biopsies like this whether there are non-atrophic tubes affected by tubulitis. This could be indicative of an acute interstitial rejection superimposed on a background of chronic changes. On the other hand, atrophic tubes, like the ones over here, invaded by lymphocytes in the tubular epithelium, may be indicative of a slightly different condition that we suppose represents chronic rejection, a smoldering, ongoing process of mild but uncontrollable tubulitis which affects the tubes in such a way that they become atrophic and in time the entire kidney will succumb under these chronic changes. Glomeruli may be relatively unaffected for some time during this process, but eventually will show ischemic changes and turn globally sclerotic, like the one over here. Recurrent disease may also be part of this process, and in that case, one should carefully search for signs of the native renal disease by light microscopy, immunofluorescence, and electron microscopy.
This patient had chronic loss of renal allograft function with interstitial fibrosis tubular atrophy known as IFTA found in the renal biopsy. The finding of IFTA is in itself a non-specific entity, but has been correlated with inferior allograft outcome, especially in case of concomitant interstitial inflammation. There are many causes for the development of IFTA, both immunological and non-immunological. The non-immunological factors include initial tissue quality, drug-related toxicity, as seen with calcineurin inhibitors, hypertension, ischemia, and viral damage, and sometimes recurrence of the original disease. Immune risk factors are histoincompatibility, reperfusion injury, poor compliance, and/or suboptimal drug dosing. In this patient, recurrence of the original disease can be excluded. The pathogenesis of IFTA is multifactorial. There is often no specific treatment unless the renal biopsy is able to identify a predominant cause. In general, the strategy is directed to optimize clinical immune suppression, treat hypertension and proteinuria, and identify additional cardiovascular risk factors such as dyslipidemia. In this patient, the CNI exposure was reduced, blood pressure treated, and an ACE inhibitor was introduced. So what can we learn from this patient? What are the take-home messages? IFTA has immunological and/or non-immunological causes. It is correlated with inferior allograft outcome, especially in case of concomitant interstitial inflammation. There is no specific treatment unless the renal biopsy is able to identify a predominant cause.
So we've now discussed two patient cases with late challenges after transplantation, namely a BK nephropathy, which can also occur earlier after transplantation, and IFTA, which is caused by a multifactorial process. In the cases, the medical information is of major importance. As an example, the first patient was at risk for BK nephropathy after an increase of the immune suppression for rejection. The second patient was already 10 years after transplantation and had various factors which could lead to IFTA, including the use of CNI for 10 years and hypertension. I would like to address one more important factor for the long-term success, namely the role of the patient himself. As an example, good compliance of the medication and a healthy lifestyle are of major importance for the success. In the patient interview, we will ask the patient about his own role in this process.